Okay, folks, we're going to pick up with cardiac surgeries. Um, so the ones we're going to talk about are a CABG or coronary artery bypass graft. So you're going to maybe hear it called a CABG, a mid-CABG or OP, um, transmyocardial revascularization, VSD repair, valve replacement, transcatheter, um, and transapical aortic valve replacement, and then cardiac transplant. Now, your coronary artery bypass grafting or CABG provides a new conduit for blood to flow to the coronary artery distal to the site of the occlusion or the stenosis. Now, this procedure results in an improved myocardial oxygen supply, and it's performed to improve both quality of life and length of life. So, quality of life by trying to alleviate the symptoms, and length of life by reducing the mortality associated with coronary events. So, a CABG may be performed alone or in conjunction with other surgeries, such as valve repair. Now, the incidence of the decision to perform a CABG is generally based on the data obtained during a cardiac cath. Arthrosclerotic lesions narrowing the lumen of the artery by at least 50% are considered significant. Lesions of greater than 70% prevent increases in blood flow to the distal stenosis despite the maximal coronary vasodilation, and thus there's a priority for a bypass. So target vessels for revascularization are assessed during the cardiac cath to ensure they're of adequate size, usually 1 to 1.5 millimeters, to support blood flow through the graft. Now, other preoperative assessments may include stress testing to verify areas of ischemia, nuclear studies to determine myocardial viability and ventricular function, and echo to evaluate the valvular problems and ventricular wall motion abnormalities. Now, there's more than 700,000 cardiac surgeries a year performed in the United States. Patients are older nowadays with more comorbid conditions and higher risk profiles than previous surgery candidates. So we've got a lot more older people that have a lot of other things going on with them. Obesity, they have diabetes, all kinds of other things. Now, clinical indications, angina is usually associated with that, with greater than 50% occlusion of the left main coronary artery, and this can't be stented. Now, unstable angina with severe 2-vessel disease or moderate 3-vessel disease or small vessel disease in which stents could not be introduced. That's another reason why they do CABG. They also can do it with ischemia, with heart failure. If a person has had acute MI with cardiogenic shock, and the signs of ischemia or impending MI after an angiography or PTCA. They will also do it if they have valvular disease or the coronary vessels are unsuitable for PTCA. Now, PTCA is basically precutaneous coronary intervention, stenting or angioplasty, and usually CABG is done when this is neither feasible or because the lesions or the location or the stenting is just not successful. In addition, certain patients with coronary artery disease have been found to have improved outcomes with surgical revascularization. I'm sorry, y'all are used to me, you know I can't pronounce things. CABG is the treatment of choice for patients with significant stenosis of the left main coronary artery, or the equivalent of left main stenosis, created by greater than 70% stenosis of both the proximal left anterior descending, or the LAD, and the circumflex arteries. Now, CABG is also recommended for patients with coronary artery disease with 3 or more vessels, especially if there's evidence of ventricular dysfunction or ischemia, or if the patient has diabetes. Now, surgery is also recommended for patients with 2 vessel disease when there is involvement of the proximal LAD. So all these reasons for cardiac surgery. Now, the selection of the conduits, a lot of times they look for the internal mammary artery, left and right, the saphenous vein, open, and EVH, and the radial artery. Now, the selection of the particular conduit for CABG is influenced by several factors, including the patient's age, the location of the vessel requiring the bypass, the conduit availability, and the surgeon's preference. Now, because improved patency rates and event-free survival have been shown with the use of arterial conduits, they're preferred over venous grafts whenever feasible. Now, frequently a combination of grafts is required to achieve a goal of total revascularization. And this just shows some of the different places that they get that from. Now, the left internal mammary artery, or lima, is the conduit of choice and is used in a majority of elective cases. It's long been shown to provide not only superior patency, that's greater than 90% for at least 10 years, but it's also improved survival with less risk of reoperation or myocardial infarction. Now, recent data suggests that the lima grafting may have a protective effect on the preoperative mortality as well. Perioperative, excuse me. The lima is also anatomically well positioned to bypass lesions in the left anterior descending artery. The right internal mammary can also be used in a situ graft or bypass of the right coronary artery, or as a free graft or bypass of other vessels. And because of the superior patency rates, some surgeons advocate for a bilateral use of the internal mammary arteries. Although this increases the length of the operation, has been associated with an increase in wound infections, especially in diabetic patients. So in diabetic patients, a lot of times you'll see them elect to do something different. Now, the saphenous vein is the most commonly used venous conduit. Now, it can be harvested directly through an open leg incision or endoscopically through a small 3 to 4 centimeter incision. Now, although they're more time-consuming, endoscopic vein harvesting, or EVH, has been shown to decrease the incidence of postoperative leg wound complications such as cellulitis or hematomas. Now, patients also report less pain and improved appearance with EVH. Sometimes lesser used veins include the cephalic vein and the lesser saphenous vein. Now, a major limitation of the venous grafts is progressive arteriosclerosis. Now, patency rates have improved slightly with the aggressive use of statins and antiplatelet agents, but still remain at approximately 60% after 10 years of surgery. Now, the use of the radial artery as a conduit for CABG has increased in the last decade, partially as a result of improved harvesting techniques and medications to prevent vasospasms. Now, this artery is usually harvested from a non-dominant hand, either through an open incision or endoscopy, and used as a free graft from the aorta or the lima. Now, patency rates of greater than 90% after 10 years have been reported for the radial arm artery grafts. And this just shows some of the grafts and their locations. Now we're going to talk about cabbage valve, preoperative PFTs, venous Doppler studies, skin prep, basically where we clip the hairs. We do either chlorhexidine or a sage wipe, nasal antiseptic protocol, Paradex oral solution, and permits. And this just goes to show the difference between Providine, iodine, and Bactroban use for surgery patients. You need to look over this. You might see this again. I'm not going to go into detail. You can read it for yourself. Now, most of the cardiac surgeries, you're going to clip the hair, usually from the head down, depending on where from the neck all the way to the ankles, depending on what they're going to use. If they know what they're going to use, sometimes it's less than that. But usually you'll have no hair from the neck all the way down to the ankles. You will also do a chlorhexidine bath or a from head to toe on these people. There's an antibacterial scrub. And here's just some of the, in this slide here, it tells you about what to use and when to use it. Now, oral care, you're going to do a Paradex, usually preoperative and postoperative, and that is to make sure that they don't have any bacteria, especially have any ventilator acquired pneumonia occur and things like that. So all these things will be used to make sure that the patients have the best outcome. Now, intraoperative, we're going to talk about IVPB, insertion of an art line, and insertion of a pulmonary artery catheter. Also, cabbage tooth surgeries, vein harvesting, and bypass portion. Now, cardiac surgeries, an open surgery is basically where they go in and it's not endoscopic. They open up the patient. There's more risk for infection, but it gives them a better view of everything. Endoscopic vein harvesting is where they go in through a small incision, and you can look you can also look at this image that kind of shows you how they go in. They look at the image on the screen, and they harvest the vein that way. Now, intraoperative, we're going to talk about intubation and anesthesia, a median sternectomy. The patient is basically placed on a bypass machine. Their heart is stopped with cardioplegia, and new conduits are created. Now, once the heart is arrested, then the grafting procedure can begin. So the surgeon uses internal mammary artery, a saphenous vein, or a radial artery to bypass blockages in the coronary arteries. Now, the distal end of the vessel graft is dissected and attached below the clot in the coronary artery. If the surgeon uses a venous graft or a radial artery, it is anastasized or sutured approximately at the aorta and distally to the coronary artery just beyond the occlusion, thus improving myocardial perfusion. And this goes to show the different things that they do. They also will put in, this is a catheter, shows how they bypass complications is related to coronary or CABG. Patients can have bleeding, so you're going to have to watch for that. It could be from the incisions. It could be internal bleeding. So with internal bleeding, you're going to watch for a reduction in heart rate, a reduction in blood pressure. You also want to watch and make sure that it doesn't get too high also. So you want to keep everything in normal ranges. You're also looking for any kind of dysrhythmias. A lot of times these patients will go into a ventricular rhythm. So you have to watch that. AFib, sometimes they'll go into arterial rhythm also. Embolize you need to watch for, since these patients could throw a clot. Also electrolyte imbalances because of the fluid volume that they lose and it given back. Sometimes they have electrolyte imbalances and fluid shifts because of the same thing. You also have to watch for hypothermia with these patients. So they're cooled down, during the surgery, lose a lot of fluids. It slows their metabolism down, and so you have to watch for that hypothermia. Also, hemodynamic instability. We talked about that with the fluid imbalances. A lot of times you're going to have to watch that pressure, blood pressure, and everything. Myocardial depression. The heart might not start back like it's supposed to. It might be depressed in some way. Also, neurocognitive dysfunction and pulmonary dysfunction. So you're looking at any kind of problems that could occur with them stopping the heart and the blood flow being less than optimal. And then systemic inflammatory response. So is the body rejecting the grafts? Is it fighting against itself? So those are all things that you need to watch for with cardiac surgeries. When the procedure is completed, the patient is going to be rewarmed if cold cardioplegia was used and weaned from the bypass machine while the grafts are observed for patency and leakage. Now, the surgeon may place arterial and ventricular pacemaker wires and mediastinal and pleural chest tubes. And finally, the surgeon is going to close the sternum with wire sutures. Now, a lot of times you're going to see these patients when they go through an x-ray, if they've had a CABG, they have little wires you can see in their sternum, holding their sternum together where they've been wired together. And this just shows some of the tubing and what they look like after they've been closed up. Now, like we talked about before, here's some of the different post-operative potential problems that you have to watch for. So let's talk about hypothermia. Now, hypothermia has several negative consequences, including bleeding, vasoconstriction, and dysrhythmias. Shivering increases oxygen demand and CO2 production. Now, rewarming may be accomplished through warm blankets, lights, or thermal blankets. The danger of rewarming patients too quickly is that they begin to shiver, resulting in metabolic acidosis and increased myocardial oxygen consumption and hypoxia. Now, to prevent shivering, rewarming should proceed at a rate no faster than 1.8 degrees Fahrenheit or 1 degree Celsius per hour. Now, you're going to discontinue the procedure when the body temperature reaches 98.6 or 37 degrees Celsius and the patient's extremities feel warm. Now, these patients need to have their temperature continuously monitored. Like we said, we want to warm them up, try to get them warm to a temperature of greater than 36 degrees Celsius. Sometimes they will administer Demerol as needed to treat shivering, and then also give them warm fluids. So they're going to warm the IV fluids up as indicated. Postoperative bleeding. Bleeding after CABG occurs in a limited extent to all patients. So you want to measure mediastinal and pleural chest tube drainage at least hourly and report any drainage amounts over 150 mLs per hour to the surgeon. It should taper off to less than 90 within 8 hours. And patients with the internal mammary artery grafts may have more chest tube drainage than those with saphenous venous from the leg. So they took the grafts from the chest, so you're going to have more drainage from the chest. You want to monitor and maintain patency of the chest tubes hourly. You also want to monitor post-operative lab results, such as their hematocrit, hemoglobin, their PTT, their platelets. You also want to obtain additional coagulation studies for continued bleeding. You're going to administer blood products and medications for bleeding, and you're going to monitor for signs and symptoms of tamponade. Now, your mean arterial pressure you want to maintain between 65 and 75. We talked about tamponade. You want to assess for, document, and report any manifestations of cardiac tamponade immediately. So sudden cessation of previously heavy mediastinal drainage, if jugular vein distension but clear lungs show up. Also pulses, paradoxis, so blood pressure at 10 degrees higher on expiration than inspiration, and then a equalizing PAWP and right arterial pressure, and then cardiovascular collapse. You're monitoring for all these different things. So postoperative blood pressure, a goal is between 90 to 150 systolic with a MAP of 65 to 75. You're looking for hypertension, also hypothermia, increased sympathetic nervous system activity. And then with hypotension, you're looking for decreased fluid volume, vasodilation, and left ventricular failure. After surgery, many patients experience hypertension. If hypertension is defined as a systolic greater than 140 to 150, hypertension is dangerous because increased pressure promotes leakage from the suture lines and may cause bleeding. So afterload reducers such as nitrazide or phenoldiazepam may be given to decrease afterload and ease the workload of the heart and prevent heart failure. Now, hypotension is basically a systolic of less than 90, blood pressure of less than 90, and is a major problem because it may result in the collapse of the coronary graft. Now, decreased preload or decreased PAWP can result from hypovolemia or vasodilation. If the patient is hypovolemic, it might be appropriate to increase fluid administration or administer blood. Now, the healthcare provider may manage the patient with volume replacement, followed by a vasopressor therapy to increase the blood pressure. However, if hypotension is the result of left ventricular failure, which increases the PWAP, then IV inotropes might be needed. Now, fluid and electrolytes, like we talked about, you're going to look at the fluid, you're going to assess for bleeding, urine output, assess for fluid shifts, and you're going to monitor their blood pressure, central venous pressure. their PAP, their PCWP, their cardiac output, uh, their CI, and their SVR. Um, so things to increase their fluid volume, albumin, heptastarch, and blood products can increase their volume. Assessing fluid and electrolyte balance is a high priority during early postoperative period. Edema is very common with these patients. However, decisions concerning fluid administration are made at the basis of blood pressure, pulmonary artery wedge pressure, or PAWP, right arterial pressure, cardiac output, cardiac index, and systemic vascular resistance, blood loss, and urine output. Now, all these things are taken into effect when decisions about fluid administration is concerned. Now, an experienced, specialized nurse interprets the assessment findings and adjusts fluid administration on the basis of standing unit orders or policies and a specific prescription from the physician. So usually these patients will have standing orders that are standard for cardiac patients. If their pressure drops to a certain amount, then they give them this fluid or this. So this is a sample of a protocol for electrolytes. Now, serum electrolytes, especially calcium, magnesium, and potassium, may be decreased postoperatively and monitored carefully. Now, because serum potassium level can fluctuate dramatically, electrolyte levels are checked frequently, and since imbalance can cause dysrhythmias, that's why it's checked so frequently. Now, potassium and magnesium depletions are common and may result in hemodilution or diuretic therapy. Now, calcium replacements based on the ionized serum calcium, and we went over this, before with electrolytes, that the actual calcium level is ionized calcium. Now, the desired potassium level is 4.0. The magnesium level should be 2.2. Now, if the serum potassium level is decreased, the healthcare provider may prescribe IV potassium replacement. Now, the dose of potassium given exceeds the usual recommended level of no more than 20 milliequivalents of potassium per hour. So for potassium replacement, as much as 40 to 80 milliequivalents can be mixed in 100 mLs of solution and given at a rate of up to 40 milliequivalents an hour. Now, the drug must be given through a central catheter and controlled by an infusion pump. The patient is placed on a cardiac monitor for intense, focused nursing observation. So you're going to watch for any type of dysrhythmias when you're giving the potassium, because it can fluctuate the other way quickly, and so you have to watch for any kind of cardiac dysrhythmias. Now, post-op, talking about dysrhythmias, major dysrhythmias that can happen: bradycardia, heart blocks, or atrial fibrillation. These patients need to be continuously monitored on an EKG, including ST segment monitoring. They need to attach the pacing wires, if present, to a pulse generator and administer prophylactic beta blockers or other dysrhythmics as ordered. And also, like we talked about, monitor the potassium and magnesium levels and replace them as needed to prevent any kind of dysrhythmias. This is just a copy of the AFib protocol, and a lot of times the patients will have this type of thing. And so you'll have an AFib protocol to follow. They'll be put on certain medications. There'll be certain things to follow. And so you might want to look over this. Now, post-op depressed myocardial function, you want to keep the MAP at greater than at least between 65 and 75. You want to keep the SVR between 80 to 100 to 1200, 800 to 1200, excuse me. And your cardiac index you want to keep greater than 2.2. Now, pulmonary dysfunction, a lot of times these patients are going to come back intubated and ventilated. They're usually going to extubate within 12 hours of surgery, and they're going to incentive spirometer after extubation. The reason for this is to prevent is to increase their lung volume and also to decrease the chances of them getting any type of pneumonia. Some patients might, usually they try to get them off within 12 hours. Some might take longer than that, depending on if they have other comorbid things. So if they have COPD or other pulmonary problems, then it could take longer to get them off of the ventilator. Your post-op pain, the doctor is usually going to have them on some type of a PCA pump to begin with, and then they will be put on PRN medications or scheduled pain medications. We need to make sure that we keep the patient's pain in check. Pain increases what? Cardiac. So your heart rate goes up, your blood pressure goes up, things like that, and complications can occur because of that. So we want to keep their pain controlled, so you need to make sure that you're staying on top of that. Post-op infection, we're going to do meticulous wound care. Usually the first dressing change, if there is a dressing, the doc is going to do that. Usually you will just support the dressing, so you'll support the dressing. If there's a lot of drainage, you need to report that to the doctor so that he can come look at it. Don't take the bandage loose. We're also going to remove the tubes and lines as soon as possible. So as soon as the drainage stops, those are going to be pulled. And you're going to have to monitor their blood glucose closely. So these patients a lot of times will go hypoglycemic. So you have to watch that very closely. Another thing about wound care is that these patients will have a lot of wounds depending on if they've had a venous graft. They'll have a leg wound. They will also have a chest wound to be taken care of, and you have to take care of those particularly well, especially if the leg graft, if it's open from ankle to groin. Those, especially because of the groin area, need to be taken care of and well maintained and kept clean. Now, insulin drip protocol, like I said, a lot of times these patients will go hypoglycemic. Sometimes they will go hyperglycemic, and so they usually will have a IV protocol, insulin drip protocol for patients that are hyperglycemic, and you will follow that protocol. And this is just a sample of that. Now VSD, left to right shunt. Necrosis and subsequent rupture of the ventricular septum is a rare and frequently fatal complication of an acute MI. Now the frequency of post-infarction rupture of the septum has declined in the era of reperfusion. It is now estimated to occur in about 1% of the patients with elevated ST MIs, so with a STEMI. Ventricular septal defects allow for the shunting of blood left to right, producing acute pulmonary edema and cardiogenic shock. So clinical signs of acute VSD include the presence of holosystolic murmur and an increase in oxygen saturation in the right ventricle. Now, a cardiac echo can be done to confirm the diagnosis of VSD. And surgical repair of acute VSD is challenging, especially in patients who are hemodynamically unstable. However, because mortality for patients managed medically is greater than 90%, surgery is currently recommended for virtually all patients with a post-infarction VSD. And this just goes to show you, so 47% mortality rate if treated surgically, if treated medically, a 90% mortality rate. So preoperative patients require inotropic support as well as afterload reduction uh, to improve forward flow from the left ventricle. Generally, an IABP inter, interaortic balloon pump is used to support the patient both before and after the operation. Now, repair of the VSD is performed through a median sternectomy on an arrested heart. The ventricle is opened and a prosthetic patch is applied to the interventricular septum. Now, the ventriculectomy is then closed using felt strips for reinforcement. Surgical repair is usually performed in conjunction with coronary artery bypass grafting or CABG to improve myocardial perfusion. Now, surgical mortality with this procedure remains high and has been reported as high as 47%. Remember, we talked about that. But 90% if it's treated medically. Post-operative care, like we talked about, an interaortic balloon pump, and as with other CV cases that have already been discussed. Now, if a mid-cab is indicated, basically mid-cab stands for minimally invasive direct coronary artery bypass, also known as keyhole surgery. Now, this might be indicated for patients with a lesion on the left anterior descending artery or LAD. In one of the most common mid-cab procedures, a 2-inch left thoracotomy incision is made and the fourth rib is removed. Then the left internal mammary artery is dissected and attached to the still beating heart below the level of the lesions. Now, coronary a CABG is not required, and after surgery, you're going to assess for chest pain, EKG changes, so Q waves and ST segment and T wave changes in leads V2 and V6 because of occlusion of the IMA graft occurs acutely in about 10% of the patients. Now, if there is a question of acute graft closure, immediately notify the healthcare provider. Patients tend to have more intercisional pain after a mid-cab than after a traditional CABG surgery, but the pain can usually be managed with oxycodone or codeine. Now, because they have a thoracotomy incision, a chest tube or smaller lumen vacuum chest tube device will be attached to them, and patients are encouraged to cough, deep breathe, and use an incentive spirometer for a week post-operatively. Now, most patients spend at least 6 hours in a critical care unit and then are discharged within 2 to 3 days after the surgery. In transmyocardial revascularization, this is laser revascularization. It's a procedure for patients with unstable angina in inoperative coronary artery disease with areas of reversible myocardial ischemia. Now, after a single lung intubation, a left anterior thoracotomy is performed and the heart is visualized. Now, laser is used to create a 20 to 24 long narrow channels, 20 to 24 long narrow channels through the left ventricle muscle to the left ventricular muscle to the left ventricle. Now, these channels are eventually allowed to allow oxygenated blood to flow during diastole from the left ventricle to nourish the muscle. Now, after surgery, the patient is transported to the critical care unit where they're hemodynamically monitored to assess for any anginal episodes and bleeding disturbances. Now we're going to talk about heart valves. Now the exact incidence of valvular heart disease is unknown. Some people have suggested that more than 5 million people have some form, moderate or severe, of valvular regurgitation. And there has been as much as 4 times the increase in hospital discharge diagnosis of aortic and mitral regurgitation over the last 20 years. In 2003, an estimated 95,000 heart valve surgical procedures were performed. Most frequent were the aortic valve surgeries, followed by mitral valve, pulmonic, and then tricuspid valves. Now, valve repair is done different ways. There's balloon valvoplasty with the mitral and aortic. There's direct open commissurotomy and also mitral valve annuloplasty. Now, balloon valvoplasty is an invasive non-surgical procedure. It's possible for stenotic mitral and aortic valves with careful selection of the patients. Now, it may be initial treatment of choice for people with non-calcified mobile mitral valves. Patients are selected for aortic valvoplasty are usually older and at high risk for surgical complications or have refused operative treatment. Now, the benefits of this procedure for aortic stenosis tend to be short-lived, and they rarely last longer than 6 months. So what they do is they go in, they insert a balloon, and they try to stretch that and open it up. Now, direct open commissurotomy is accomplished with a cardiopulmonary bypass during open heart surgery. Now, the surgeon visualizes the valve, removes the thrombi from the atria, and incises the fused leaflets or commissures and debrides the calcium from the leaflets, widening the orifice. Now, in a mitral valve annuloplasty or reconstruction, it is a reparative procedure of choice for most patients with acquired mitral insufficiency. Now, to make the annulus or the valve ring that attaches to and supports the leaflet smaller, the surgeon may suture the leaflets to an annuloplasty ring or take tucks in the patient's annulus. Leaflet repair is often performed in the same time, and elongated leaflets may be shortened, and shortened leaflets may be repaired by lengthening the cordae that bind them in place. Now, perforated leaflets may be patched with synthetic grafts. Now, annuloplasty and leaflet repair results in an annulus of the appropriate size and the leaflets that can close completely. Thus, regurgitation is eliminated or markedly reduced. Now, different types of valve replacement. They can be done with prosthetic, synthetic, and those are ball caged or bileaflet or biologic tissue, a xenograft from another species, sometimes a porcupine, from a pig, sometimes from a cow, or pulmonary artery grafts. Now, an aortic valve can be replaced only with a prosthetic valve from symptomatic adults with aortic stenosis or aortic insufficiency. A biologic valve cannot be used because of the high pressure within the aorta. Now, xenografts are not as durable as prosthetic valves and usually must be replaced every 7 to 10 years. And these don't require anticoagulant therapy. Mechanical valves can either be cage ball or bileaflet valves. There are 3 mechanical valves available: St. Jude's, Cardiomedics, and Medtronic Hall valves. The most common mechanical valves used today are low-profile bileaflet disc valves, which offer less impedance to blood flow through the orifice. Now, complications associated with prosthetic heart valves include structural valve deterioration and the peripheral embolization related to thrombus generation of the valve suture. Additional complications include prostatic endocarditis, prostatic dehiscence, bleeding, perivalvular regurgitation, and primary valve failure. Now, hemolysis also occurs with mechanical prostatic valves, but not with tissue valves. An increase in the concentration of lactic acid uh, dehydrogenase, or LDH, has been found to be more reliable as an indicator of hemolysis. Now, prostatic dysfunction, perivalvular leak, or clot tear will produce a sudden increase in the LDH concentration. Therefore, the patient should be monitored closely for these problems. So you're going to monitor their lactic acid. And so here's a picture of some of the valves, biologic valves, the St. Jude's valve. Valve replacement surgery is basically the same kind of care as with a patient with a CABG. They'll have anticoagulation with prosthetic valves, and antibiotics need to be given prior to any dental or surgical procedures. Now, the transapical and transcapular catheter aortic valve replacement is a new approach in replacing aortic valves. The transcatheter is via vascular access. The transapical is a 5 to 8 centimeter anti-arterial lateral thoracotomy in the 6th ICS. Now, minimally invasive techniques have expanded for patients who are non-surgical candidates. So transcatheter aortic valve replacement, or TAVR, is an alternative option for treatment of aortic stenosis. Now, a bioprosthetic valve is placed percutaneously via either transfemoral or transscapular route under general anesthesia in a hybrid operating room. So that's a combination of a cath lab and a cardiovascular operating room. Now, after initial balloon aortic valvoplasty, the new valve, which is wrapped around a balloon on a large catheter, is inserted into the femoral artery. Now, the patient is transvenously placed at a rate of about 200 beats, transvenously paced at a rate of 200 beats per minute to mimic ventricular standstill. The balloon is then inflated and the valve deployed. If the transapical approach, a small incision is made at the apex of the heart. Now, the catheter is then threaded through the incision and the left ventricle to gain access to the aortic valve. Now, as in the transvenous approach, the balloon and catheter is deployed during rapid transvenous pacing. Now, this procedure is performed by a healthcare team consisting of interventional cardiologists and cardiovascular surgeons. The team can also be prepared to convert an open or traditional aortic valve replacement if necessary. So care of the patient is similar to the care of those patients undergoing a CABG. However, this patient population only needs anticoagulation with aspirin and clopidogrel post-procedure. And that's CLOPIDOGREL. And this is just a slide that shows a TAVR, how they accomplish that. Now we're going to talk about heart transplant. Heart transplantation is a surgical removal of a donor heart with a donor heart. Surgical replacement with a donor heart is the treatment of choice for patients with severe dilated cardiomyopathy and it also may be considered for patients with restrictive cardiomyopathy. Now, the procedure may be done for end-stage heart disease due to coronary artery disease, valvular disease, or congenital heart disease. Now, the criteria for selection is usually heart transplant. They have to have usually a life expectancy of less than a year. Age is generally less than 65 years of age. They have to be rated on the New York Heart Association scale as either a class 3 or class 4. They have normal or only slightly increased pulmonary vascular resistance. They have an absence of an active infection, stable psychosocial status, and no evidence of recurrent or current drug or alcohol abuse. And this just shows you how the surgery goes, this slide. So after the recipient's placed on a cardiopulmonary bypass, the heart's removed, posterior walls are left intact, and then the donor heart is sewn in. Heart transplant, immediate post-operative care is similar to other cardiac surgeries. You're going to look for cardiac tamponade, rejection, rate control, and increased rate of infection. Cardiac tamponade, you want to look for any kind of findings, so significant decrease in mediastinal chest tube drainage, JVD, paradoxical pulse, decreased cardiac output, muffled heart sounds, circulatory collapse, or increased CVP, PA, or PAWP. However, the nurse must be especially observant to identify occult bleeding into the pericardial sac with the potential for tamponade. The patient's pericardium has usually stretched considerably to accommodate the diseased hypertrophied heart, predisposing him or her to have concealed postoperative bleeding. So that has to be watched because the sac, the place where the heart is, has been stretched so much. Now, rejection, what you're going to look for with that is you're going to look for shortness of breath, fatigue, if they have fluid gain, so increasing edema, increased weight, abdominal bloating, if they have a new onset of bradycardia, hypotension, AFib or flutter, have a decrease in activity tolerance, and a decreased ejection fraction, and that is a late sign of heart transplant rejection. Rate control, you want to look for a transplanted heart is denervated or disconnected from the body's autonomic nervous system and is unresponsive to vagal stimulation. Bradycardia, with bradycardia, they're unresponsive to atropine. You're going to use isoproterenol to increase the rate, and it may require ppm. Now, tachycardia does not respond to digoxin, does not respond to vagal maneuvers, and orthostatic hypotension, you're going to change positions slowly if these patients have that. Now, heart transplant, long-term post-operative care. Rate control is going to usually be controlled by a pacemaker. Rejection, you need to look in your book. They do routine biopsies of the tissue to check it. They'll also be on daily anti-rejection drugs. Now, coronary artery vasculopathy, which presents as a diffuse plaque in the arteries from the donor heart. This cause is thought to involve a combination of immunologic and non-immunologic processes that result in vascular endothelial injury and an inflammatory response. Because the heart is denervated, patients usually do not experience any angina. Regularly scheduled exercise tolerance tests and angiography are required to identify CAV. Um, so these patients, to prevent this, they're going to be looked at with their regular scheduled look at nutrition, their statins, stents, and CCB. Now, corticosteroids broadly inhibit cytokine production in most leukocytes, resulting in generalized immunosuppression. So you need to watch that. Also, prednisone. Um, now, calcineurin inhibitors. Uh, the inhibition of calcineurin stops the production and secretion of IL-2, which is then prevents the activation of lymphocytes involved in transplant rejection. So cyclosporin, things such as Sandamune, Neuro, or Gengraph will be given, and also Prograf can be given. So the drug regime to help with rejection. The last thing we're going to talk about, one of the last things, is ventricular assist device, or LVAD. You can watch this little thing on YouTube here. What is it? How does it work? All that will be answered on that if you want to look that up and watch that. And the IABP, basically intra-aortic balloon pump when patients don't respond to drug therapy, with improved tissue perfusion, decreased workload of the heart, and increased cardiac contractility. A intra-aortic balloon pump can be inserted. Now, the AABP is an invasive procedure that is used to improve myocardial perfusion during acute MI, reduce preload and afterload, and facilitate left ventricular ejection. Now, inflation of the IEP during diastole augments the diastolic pressure and improves coronary perfusion by increasing the blood flow to the arteries. Now, deflation of the balloon just before systole reduces afterload at the same time of systolic contraction. Now, this action facilitates emptying of the left ventricle and improves cardiac output. The balloon catheter is attached to a pump console and is triggered by EKG tracing and arterial waveform. So, why do we use it? We want to increase cardiac output, increase ejection fraction. We also want to increase coronary artery perfusion and decrease myocardial O2 demand. You can also watch this little thing on YouTube. We'll explain it a little bit more. That's all we have for cardiac surgeries. The last thing we're going to talk about is invasive hemodynamic monitoring, and that will be next.